Dr. Hilary Allen today for giving our webinar. Hilary is a GP with a special interest in allergy, and she runs an allergy clinic in Spiddal Medical Centre. But she also works in the paediatric allergy clinic in University Hospital Galway with paediatrician Dr. Edina Moylett. And Hilary has undertaken a master's in Allergy Medicine in Imperial College London, and she's running a Penicillin Study as part of this, and she'll mention this at the end of her webinar. So I'd like to hand it over to you now, Hilary. Thanks very much, and looking forward to your talk.
Thanks, Nikita, and welcome everyone, and thanks for taking the time to share this talk with me. So I'm talking about allergy today, and I'm really doing it from a primary care perspective. I'm going to start with a few definitions. I apologize if this is a little bit too easy for some people, but everybody has different backgrounds in their knowledge with allergy. So I wanted to mention atopy, and the reason I want to mention that is this is a genetic predisposition to producing IgE antibodies. What's important with that is there are a lot of people who can produce IgE antibodies who are sensitized, but they may not have allergic disease. And that's important so that we don't do blanket testing or serum IgE testing to people with, for example, atopic eczema, because they will often be sensitized but not actually be allergic. And unfortunately, I see a lot of children who have foods taken out of their diets based on testing alone, but actually they would be able to eat these foods without any difficulty. So they may not be allergic, but they are atopic. Hypersensitivity is defined as something that's reproducible. So symptoms that are reproducible when people come in contact with an environmental allergen, but most people don't react to it. So within hypersensitivity, we're looking at allergy and non-allergy. So allergy, of course, is immune mediated. So it's an immune reaction to an allergen or to an environmental protein, okay? And non-allergic hypersensitivity, you're getting into the domain of intolerance. So it's non-immune mediated. And just to illustrate that a little bit further, so our hypersensitivity reactions, allergic and non-allergic, and then within allergic, we are always thinking about what's IgE mediated and non-IgE mediated. So your IgE mediated reactions are your immediate reactions. We're all very familiar with anaphylaxis. And then your non-IgE mediated reactions are the slower or the delayed hypersensitivity reactions. So they're non-immediate. So as you know, we're all seeing an absolute epidemic of allergy, and just what's important to point out is it's expected that up to 4 billion people worldwide will be affected by allergy by 2050, so it's quite substantial. Now, we're all very familiar with anaphylaxis. The reason that I put up this slide was just to draw your attention to the clinical criteria number 2. And again, it's because at times in my allergy clinic, I'm often seeing what really is an anaphylaxis, but often gets missed. So if you look at the clinical criteria 2, I want to draw your attention to persistent gastrointestinal symptoms, so persistent vomiting. So 2 or more of the following symptoms on exposure to a likely allergen. So for example, I saw a child recently who every time she took a peanut, she would get a tiny bit of lip swelling, and then she would have persistent vomiting for about an hour. This was an anaphylaxis. She wasn't given an adrenaline pen because nobody recognized it as anaphylaxis because she didn't have her respiratory symptoms. But persistent vomiting, you are thinking, okay, maybe this is an anaphylaxis. So again, just mentioning with regards to food allergy, your IgE mediated and non-IgE mediated, just to remind you that non-IgE mediated is a delayed hypersensitivity. So these reactions are slow and they're hard to diagnose, but they usually come up as gut symptoms, but also worsening of eczema. So again, it's good to have that in the back of your head if somebody's presenting with gut symptoms and they might be an atopic individual, so they might have other sort of allergic conditions. So I'm going to start with my first case. This is quite an easy case. So a 6-week-old baby, something we often see in general practice. They come in as unsettled, colicky, refluxy. Mum tells you they vomit back the whole feed. They're constipated, fully breastfed, but they're growing very well. So my question to you is, would you think this could be allergy? So if you want to type in your answer, if you think this might be allergy. I'm going to move on through the case. I'll let you keep typing it in and have a think about it, but I will keep moving through because I have a few cases and it's quite a long talk. So in thinking about if this possibly could be allergy, because my question to you is, what would you be thinking? what would be your first question? So I see, thank you, Susan Smith, could be lactose through the breast milk. So I guess lactose is sort of lactose intolerance, and lactose comes into sort of non-allergic hypersensitivity, but lactose it's rarer. So the question you'd be asking yourself in this case is this baby from an atopic family? Okay, so could this be allergy? And so what I want to draw your attention to is the iMap guidelines. So thank you, Andrew, for your text in there that you wouldn't think of it immediately, and that's exactly the purpose of this talk, because I want people to think of it. A lot of kids are getting given Gaviscon, or they're getting given Losec for reflux, but really reflux is a normal physiological process. So you always want to think in the back of your mind, well, maybe this is a possible cow's milk protein allergy. And your first question would be, is this family, do they have a history of atopic disease? So the iMap guidelines, anyone can download them onto their desktop. They were designed specifically for primary care, so it's milk allergy in primary care, and they give a very nice history that you can use in a 15-minute consultation. They also produce a protocol for how would you manage this if you suspect that it's cow's milk protein allergy. So remember, milk protein allergy can be IgE mediated, which are your immediate reactions. So your lip swelling, your urticarial rash, your difficulty breathing, they're immediate IgE mediated. That's always under the domain of a paediatrician. That's something that you would refer off straight away. What you can look at as a primary care physician is the non-IgE mediated. And so within non-IgE mediated, you're looking at mild to moderate disease versus severe disease. And severe disease always goes to a paediatrician as well. So you can see this little box. You can look at this after the talk yourselves. But severe would be gut symptoms. So I said delayed hypersensitivity can be gut or skin symptoms. These children are sometimes failing to thrive. So they would be referred off to a paediatrician. But for ourselves in primary care, we can look at the mild to moderate cow's milk protein allergy. And it gives a nice sort of protocol for how would you manage it. There's no test for non-IgE mediated. We have no blood test, no skin prick test for that. It's a case of taking all dairy out of the diet for a couple of weeks and then reintroducing. It's really important that you reintroduce, because that completes the test. So if the symptoms go away when you take it out of the diet, if they come back when you put it into the diet, well, then you're confirming that this is cow's milk protein allergy. And then you're looking at different formulas. So for example, your Aptimal Peptide, your extensively hydrolyzed formula, if they are bottle fed, or you might start looking at removing dairy from the mum's diet if they're a breastfed baby. It depends on the severity of symptoms. So again, they have a lovely protocol as you move onto how do you exclude the milk, what you use alternatives, and then most children will grow out of cow's milk protein allergy. So you might look at reintroducing into the diet after about 9 to 12 months, again, depending on their symptoms and depending on whether they have atopic eczema or not. So these guidelines you can download onto your desktop. I wanted to mention the iMap milk ladder, because when you are looking at a reintroduction back into the diet, you can use a milk ladder. So this might happen at a year or 18 months of age. And what's important about this milk ladder is that it's used for non-IgE milk allergies. Sometimes I see people using it when they've had urticarial rash or immediate symptoms, and it's not appropriate for that. It's to be used for the non-IgE symptoms, so the gut symptoms. And basically what parents do is they start with foods that have some dairy in it, maybe in a cooked form, in a biscuit or a muffin, and they work their way up to be able to actually take milk or a suitable formula into the diet. So again, this is on the iMap guidelines that you can download. Now, so I'm going to move on to case history 2. So this is a 6-month-old baby fully breastfed. Mum decides to wean, introduce a formula feed. They develop profuse vomiting, lasting approximately an hour. They're pale, lethargic. They didn't have any rash or skin symptoms or any respiratory symptoms. They're seen in A&E. And they have a negative septic screen. They're given IV fluids and antibiotics. They fully recover within 12 hours. Anyone any ideas what the diagnosis might be there? Or what would you be thinking? Yeah, so that's true. The antibiotics might have worked. It's one of those cases where you're not quite sure, so you sort of hit them with fluids, antibiotics, hope they recover, and that's exactly what happens in A&E. So just moving on through this case, I want to say that the patient was discharged from A&E and told to follow up with their GP. No specific diagnosis, probably infection, as you said, probably responded to the antibiotics. And that's a good point too, IgE mediated. Could it be IgE mediated? Could this be an anaphylaxis? So my question is, would you prescribe adrenaline pens? Patient comes back to you. So no. Okay, that's good. All right. So it's probably a little bit unfair because I didn't give you the timing. So just going back, I said this baby developed these symptoms, but I didn't say how quickly they developed them. But what I want you to have in the back of your mind, this is really rare, but it's FPIES. So food protein induced enterocolitis. I'm not sure if anyone's heard of it. If you do come across it, you probably get one case in your lifetime if you do, but it's on the severe end of the spectrum of non-IgE mediated food allergy. So non-IgE mediated, so it's not an anaphylaxis, it's a non-IgE mediated, which means we have no test for it. And what happens is this presents in early infancy. It's generally, there's a family history of atopy. So you're always thinking allergy if there's a family history of atopy, and it presents like sepsis. So vomiting, diarrhea, lethargy often gets treated like sepsis, and usually what happens is these kids present to A&E 2 or 3 times with a kind of a septic picture, and nobody thinks of FPIES. So the question of atopy is important. Your skin prick testing is negative, or your serum IgE is negative. However, in about 25% of cases, you will get positive skin prick testing, but that's atypical. Those kids are coming into a mixed IgE and non-IgE picture, which is a little bit more risky. They may end up with adrenaline pens. They also are less likely to grow out of it. The most common food is milk. So the most common food is milk, but they also can get soya, rice, oats, wheat, fish, and shellfish causing it. Most react to only one food, sometimes to 2. It's very much under the domain of the pediatricians and actually the paediatric allergist specialists. They usually resolve within by 5 years, and sometimes the pediatricians will start to look to oral challenge them. What I mean by oral challenge is because there's no test for this, they actually bring them into hospital under controlled conditions where you give the food and see do they tolerate it. That might happen after 3 years of age. Okay, so FPIES is just a condition to have in the back of your head. Usually the mum will come in and say, every time I give this food, this happens. And this is a condition that will be seen very quickly in pediatrics if you do refer. Okay, so number 3, the case history. I'm sorry for moving so fast through this, but quite a bit to get through. So this is a 7-month-old baby with atopic eczema since 2 months old, formula fed. First time to have scrambled eggs, and within 10 minutes gets urticarial rash, swollen lips and eyes, irritable, vomits once, but recovered within 2 hours. So again, would you prescribe an adrenaline pen in this situation? Yeah, so I think that's all very reasonable. You're right, the baby is young, but this is really generally the time where you start to see these symptoms coming in when they start trying them with a little bit of egg. But you're right, an adrenaline pen, I probably wouldn't prescribe an adrenaline pen because the symptoms there are confined to skin only. However, again, you're always assessing risk with allergy. So if they were a particularly atopic family, then you might think again, but it depends on the history. Okay. And again, you're right, is it once off, how much was eaten? So I just wanted to show you the indications for adrenaline pen. So this is the European Academy of Allergy and Clinical Immunology, which give very nice guidelines, very good website. So your absolute indications are obviously anaphylaxis, venom allergy, and mast cell disorders such as mastocytosis in the context of venom allergy. Then relative indications are a mild to moderate reaction to peanuts. So peanut allergy nearly always gets an adrenaline pen. Teenager or young adults, because these kids are a little bit more risky with food. food allergy, so they might, go out and eat in restaurants, or they won't be as good at avoiding the food. Remote from medical help, or a mild to moderate allergic reaction with very small amounts of food. There is no right or wrong. No one's going to criticize you for prescribing an adrenaline pen, to be careful about it, but it is good to know what the absolute and relative indications are. What I would point out to you is that if you're prescribing an adrenaline pen, you need to be giving an allergy action plan. So this is from the BSACI website. It can be downloaded free. And basically they show patients how to recognize a reaction. They also have ones that have the actual adrenaline pen and a picture of how to use the adrenaline pen. What I wanted to draw your attention to was the little box on the left hand side is for mild to moderate reaction. So this is antihistamine only, and these are skin symptoms. If you look at the box for anaphylaxis, what's really important here is how you position your patient after you give an adrenaline pen. So patients should always be, once you administer an adrenaline pen, they need to be lying down or sitting. So what they can't do is walk to the ambulance when it arrives. If you've administered an adrenaline pen, then they have to call an ambulance. They have to be sent to hospital. They must be lying or sitting. The reason for that is that they can recover from the adrenaline, but then when they go to walk to the ambulance, there's a pooling effect, and they end up getting a heart attack, and that's actually what kills them, so not the anaphylaxis. So that is an important point. Okay. So just keeping with case history 3 with the scrambled egg. So mum's nervous about introducing other foods into the diet. So my question is, should she remove all egg from the diet? And then my second question is there any other foods to remove from the diet? So we might just start with removing all egg from the diet. Would you get her to take all egg out of the diet until she's seen her allergist? Yes, okay. Yeah, so often it's easier to say just avoid all egg, just to be careful about it. But actually this is a picture of the egg ladder from the Irish Food Allergy Network. So egg is a little bit different in that you can tolerate egg maybe in well-cooked forms, but you may not be able to tolerate it in less well-cooked, so lightly cooked forms. So the answer to the question about removing all egg from the diet, I understand this baby's only 7 months, but if they were a little bit older and they already had, some bread or cakes in their diet that contained really well cooked egg, and they had no problem, they weren't getting any reaction with it, the message is you would leave whatever egg is in the diet that they're already tolerating. Okay, so they would avoid the scrambled egg or anything that's almost raw. So you can see scrambled egg comes into almost raw, but if they were down here with having, say, a cake that had well cooked egg, mum had cooked it herself and they had no reaction with that, you would keep that in it. Okay. So going to the BSACI guidelines, egg allergy is, most people grow out of egg allergy, and reactions with egg tend to be milder. They'll often tolerate well-cooked egg, as I said. If they have had mild symptoms and there's no asthma, then you can look at reintroducing the egg from 3 years of age. So you're quite right, you start looking at the egg ladder. However, you shouldn't reintroduce it if it's within 6 months of a significant reaction. What I wanted to remind you is about the vaccines. I'm sure you're well aware of this. They can have their MMR. The influenza vaccine, they can have whichever brand has less than 0.6 micrograms of ovalbumin. If they, for some reason, needed yellow fever vaccine, then you'd refer to an immunologist. What's important to remember is when you're thinking of egg allergy, so atopic eczema, egg allergy, peanut allergy and asthma all run together. So if you have atopic eczema, you're at higher risk of an egg allergy. If you have an egg allergy, you're at higher risk of a peanut allergy. And then when you bring asthma into that, that changes everything, because asthma makes it a little bit more risky. So in answer to the question, is there any other foods to remove from the diet? Well, we don't like removing foods from children's diet, but if they have had a reasonable reaction, they've got atopic eczema, we need to start thinking about peanuts. So if peanuts already in the diet and they have no problem with it, we're not going to be taking them out, okay? So I'm sure you're familiar with the LEAP study. This was a UK study. And it was done because they recognised that there was an increase in peanut allergy in UK children when compared to children in Israel, where peanuts was sort of part of the diet. And they felt this was because there had been a lot of advice to pregnant women about not eating nuts during pregnancy and to prevent peanut allergy. So what they looked at was assigning children to either consume or avoid peanuts. So they all underwent skin prick testing. These were kids who already had risk factors for peanut allergy, such as eczema, egg allergy, or both. And then they assigned each of them within each skin prick test. So a positive skin prick test is 3 millimeters. So a skin prick test of 0 millimeters was negative, and within that group they assigned them randomly to consume or avoid. The same with the skin prick test of 1 to 4 millimeters. And what they showed is by consuming peanuts regularly, they actually showed a reduction in developing peanut allergy. Okay. They moved on to do the Leap On study. So of the original participants, 556 were followed up for 1 year, and that included consuming peanuts and avoiders of peanut. And they showed that 4.8% of the original peanut consumers were allergic. Sorry, now I'm just after losing that case. Sorry, I'll just go back to it now.
I'm just concerned for time, Hilary. We've got 4 minutes left.
Yeah, I only got 5 minutes left. Okay. Sorry. So basically, the Leap On study showed that tolerance is maintained even without continuous consumption of peanuts. So if you get peanuts in early into the diet, you can actually prevent peanut allergy. So just moving on, the last thing I wanted to say about that case is that if that child becomes a recurrent wheezer, so at 2 years of age, they're a recurrent wheezer, it's a bit early for asthma, and they've already been prescribed adrenaline pens, just to remember that asthma changes the picture. So you want to continue, if you've got a peanut allergy and you're a wheezer and mum comes into and says, I can't afford these adrenaline pens, I've never had to use them, do I really need them? Well, yes, you do, because now you're getting into risk factors for asthma, and that, of course, increases your risk for having a serious reaction with a peanut allergy. Okay. And the other question that I often get is about a sibling. So a 6-month-old sibling who has mild eczema and mum hasn't introduced egg or peanuts into the diet, what would you do? Would you tell her to go ahead, or would you refer for testing? So with the BSACI guidelines, it's not so clear on what we should do with egg, but with nuts, the prevalence of a peanut allergy in a sibling is about 5 to 9%. So the general advice is if there's no eczema, asthma or food allergies, you could cautiously introduce it at home. But if you've got a high risk sibling or your parent is really anxious, then you might do testing first. Within general practice, you could do a serum IgE test on these kids. It's very helpful if it's negative. If it's not negative, then you're looking at having to refer for an oral challenge. Okay, so I'm sorry to have flown through that talk, and I hope it's helpful. I want to finally mention just the study that I'm doing at the moment in UHG. So this is a study at looking at delabeling penicillin allergy in children in an outpatient setting. So these are kids that have been labelled as penicillin allergic because they got a skin rash while on an antibiotic in early childhood. Usually it's from a viral illness, but they have carried this label going forward. And so what we're doing is there's no blood test or skin test that's accurate in this situation. What you have to do is just give them a dose of penicillin. In the past, they used to do graded challenges, but we're actually doing a single dose challenge because these children are quite low risk. And so our aim is to challenge 100 children to remove that penicillin label in 100 children under the age of 16 years. And the hope is that we might be able to show that this may be possible or may be reproducible in primary care in the future. So if you have any children under the age of 16 who are labelled penicillin allergic and you think they might be interested and they consent to me contacting them, please do email their details to penicillin.allergy@hse.ie, and I'll be happy to follow up with them and keep them in the study. The study will be finishing in May 2019. So that is it for the moment. Nikita, I hope that helped. I hope I've answered most of your questions or that you found that useful. I'm happy to take any other questions via email. I've included my email on the talk. Okay.
Thanks, Hilary. That was so interesting and really excellent interaction as well with our participants. So we did actually we have a little bit of time at the end for some further questions if anybody has. I just have one there from Andrew.
Yes, we're doing it on children between the age of 1 and 16. You're right. We've decided to have our cutoff at 1 year of age. So 1 to 16.
That's great. Any other questions? Do you want to speak about how the recruitment is going, how the study is going at the moment?
Yeah, recruitment has been excellent. So we have advertised in the A&E departments, and I've reached out to general practice in the Connacht area. So far we have about 74 patients enrolled. Not everyone's meeting the criteria. I've challenged 25 patients so far. They've completed the challenge without any reactions whatsoever. And I'm hoping to get the rest of them challenged over the next couple of weeks. So I have to say that the one thing that has surprised me about this study is how happy parents are undergoing this. And the other thing I'm looking at is whether they would be happy to do it in a GP practice, and nearly all of them are saying yes. The most common reason for not meeting the criteria, well, I suppose the commonest one was really just the immediacy of symptoms. So I'm looking for a cohort of low-risk patients. So one of the exclusion criteria is if they had a skin urticaria rash or maculopapular rash within an hour of having the antibiotic, they are excluded, because that could be IgE mediated and more likely to be coming into anaphylaxis. Do they have the challenge at your practice? No, not yet. I'm hoping that we will be able to do a feasibility study in general practice next year. At the moment, I tried to do it in general practice. I couldn't get the medical indemnity for it. So this is the reason for doing it in outpatients, because it's the sort of a similar, I suppose, setup to you would have in general practice, because at the moment oral challenges to drugs are done in day wards. They're admitted to the hospital. So what we're doing in the study is a little bit different for two reasons. One, it's in an outpatient setting, and two, it's a single dose protocol, and we're screening the children via telephone consultation. Okay. So
and it's only in Galway University Hospital.
I'm doing it in University Hospital Galway. I'm sorry, I can't take any patients from Dublin, unfortunately.
Okay, I think that's great. If there's any other questions, I think we're all good. So that's great. Thanks everyone for your participation today. It was really lively webinar, which I really enjoyed, and I learned loads. So we do have CPD points pending at the moment, so we will be in touch when these are actually granted. And we've recorded this webinar, and it will be available on our website later this evening. And then our next webinar is a rescheduled webinar from Professor David Finn on the endocannabinoid system and medical cannabis, HyperHope, and this is on Tuesday, April the 9th at the same time, lunchtime. We had some technical difficulties the last time. So I just want to say a huge thanks again to Hilary again for your excellent webinar and for coming on and presenting today. So thanks everybody for your participation as well. We'll see you again soon.
My pleasure. Take care. Bye.